NEI Spring Congress is headed to my home of Florida, May 1st through 3rd, and I hope you'll join me. Come for the latest in psychopharmacology. Stay connected with like-minded clinicians and experts. Walk away with the tools that make a real difference in clinical care. Registration is open now, and spots are filling fast. Use code NEIPOD26. That's all capitalized, NEIPOD26. Register now at nei.global/spring.
Welcome to the NEI podcast, PsychopharmaPearls, a brand new series created for busy clinicians. Hosted by Dr. Andrew Cutler, psychiatrist, psychopharmacologist, and chief medical officer of NEI. These 30-minute episodes deliver practical psychopharmacology pearls and real-world strategies you can put into practice right away to better support your patients.
Hello and welcome to our new podcast series, PsychopharmaPearls. And with me today is a very good friend, Dr. Lisa Harding. We'll be talking about ketamine and esketamine, something she knows a lot about. Lisa, how are you?
I am great, Andy. Thank you for having me on. I think small cuts of really important information is really important for learning. Absolutely.
And we want to be very clinically focused and practical here. And I know, again, you're in the trenches here. So we're going to be talking about ketamine and esketamine. And there's some controversy around which one and when to use which. So how should prescribers understand ketamine versus esketamine? And is there a difference that I should be aware of? When would I choose one or the other?
Absolutely. In fact, full disclosure, I am a site PI. There's a clinical trial underway right now. It is a 5-year clinical trial, a non-inferiority trial. And It is trying to let us know whether or not there's a clinical, meaningful difference between ketamine and esketamine. It's funded by PCORI, and we are trying to we're randomizing patients to either ketamine or esketamine to answer these questions, because a lot of people, very big names in the field, have very big feelings about which one versus the other. And I think in all practical aspects in 2026, intravenous ketamine is off-label for every single psychiatric indication. And a lot of the times, even though we think of insurance companies as not choosing what care a patient gets, in the essence of who is paying for the treatment really will determine what treatment a provider can give or present to a patient. We think of our Medicaid and Medicare patients that don't have disposable income, even patients with commercial insurance who are struggling to make ends meet. You can look at the prices of ketamine go from $1,200 to $500 across our country.
Wow.
And so it's less about being able to choose one for the patient, but what is covered. There are limitations on the esketamine portion of this. Esketamine is only covered for patients who have a diagnosis of treatment-resistant depression, or for the depressive symptoms of patients that are acutely suicidal that have depression. Bipolar depression isn't covered, OCD isn't covered, and those are limitations of who is covered. So it's really important to look at the current evidence. The biggest, I think, takeaway from this point is that there is no long-term efficacy and safety data of repeated administration of intravenous ketamine in a randomized controlled trial. And that is why PCORI has funded our trial. And if you want to talk about maintenance of effect, definitely there's more safety data on the esketamine side.
Of course. No, that's a fantastic answer. I'm really excited about this study. I think it will answer a lot of questions. And, it's sad but true, Lisa, we don't always get to make the pure clinical decision on what we think is best. Sometimes insurance companies, payers will dictate to some degree. Let me back up and sort of, for the audience who may not be as familiar, ketamine is a racemic mixture, of course, of S and R isomers. And so the S isomer is the one we're talking about that is commercially available. It's intranasal. Ketamine, the racemic, as you mentioned, people have to pay out of pocket, and it's available. IV was what some of the trials were done, but there are people now who give it IM, sublingual, these other things. What are your thoughts about these other ways of giving ketamine?
Yeah, so definitely. So as you said, these are mirror images that can't be superimposed on each other.
Hmm.
If you think of the pure biochemistry portion
Hmm.
of the molecule. So
Hmm.
what do we think that we know about the cleaved molecule, which is just the enantiomer? And for
Hmm.
those of you new to pharmacology, F-citalopram and citalopram sort of have the same relationship. So
Hmm.
S-citalopram
Hmm.
is the S enantiomer of
Hmm.
citalopram, and these are the
Hmm.
same. What that means in vivo in a person, we
Hmm.
do know that that S enantiomer binds more potently to the
Hmm.
NMDA receptor. But what
Hmm.
that means in a human, we're still
Hmm.
trying to figure that out.
Hmm.
We are really, I think, the portion of medicine that sort of deals with development of molecule into human being and sort of
Hmm.
into what
Hmm.
that means clinically is still
Right.
a really big black box. And I
It
think
is.
that's why people struggle with translating the
Hmm.
pharmacology or even the
Hmm.
studies to what
Hmm.
happens in a human being. So does that answer the
Right.
question about the pharmacology portion of it?
Well, a little bit more to that, yes, and a little bit more to that, of course, is the reason my understanding is that the company used the S is because it is more potent and allowed a smaller fluid volume, so intranasal instead of IV. But R is certainly not inactive, and they actually have somewhat different MOAs. And preclinically, there's some differences in animal models. But like you said, in humans, we just don't know. And there's a lot of like opinions people have, but the question hasn't
Yeah.
been answered yet in a real clinical trial.
And there's a lot floating around out there as well that the R-ketamine portion of it is more dissociative. There are a couple of studies in Brazil. One, if you want to go down a nerd rabbit hole, look at the studies in Brazil. Brazil, the entire country actually does not use racemic ketamine, not even for anesthesia purposes. In that country, they use esketamine even for their anesthesia purposes. And so it tells you what they're looking and leaning towards in terms of safety profile. So moving on to the route of administration, it's also not apples to apples because in our clinical trial, it's intravenous ketamine versus intranasal esketamine. So as you know, anything that goes into the vein is 100% bioavailable. You're taking it right to the maker. Um, intranasally, be, di- I tell people if you remember where OG COVID, those long swabs that they were inserting that went to the posterior nasopharynx, and that's where we think a lot of the absorption happens. Patients get side effects because you get postnasal drip, it goes into the sinuses. So there's a little bit reduced bioavailability. Some PK studies and all the other things you look at will see it ends up about roughly, I think safely we can all agree on 50%. Sublingually, it is about 20%. And that's why I think many of us express concern with a lot of the companies doing different kinds of ketamines and really, really these very high doses to get to the equivalent of what the intravenous would be. And intramuscular is not as linear, the absorption, and some people describe it as biphasic, but that can also get up to 80 milligrams. 80% bioavailability. The question becomes monitoring and safety. That's what it is. And I am always on the side of, in the absence of data, I do not assume something is safe.
Hmm. Hmm. I think that's a reasonable assumption. That's fair. Very fair. Yeah, I've always thought you've answered that so well because I've always thought that IV is so much more predictable in the bioavailability, and IM sublingual it's variable. Actually, it's a lot more variable. Not only between you and me intrapersonally, but also interpersonally, but intrapersonally, me from injection to injection or whatever.
Yeah.
So very interesting. Okay, let's move on then. As far as let's say now, okay, you've got a patient with difficult to treat depression. We're not going to get into the controversy of TRD versus DTD because that's a lecture we've had at the NEI Congress, and it's a whole other topic. And offline, I want to get your thoughts on that. But for the sake of this, you got somebody with difficult to treat depression. How do you decide? How do you decide which kind of treatment you're going to go for here?
So I think, if we're talking that, I had both treatments covered equally. I think we've not done really a good job of phenotyping patients. We don't talk about how hard it is for a clinician to refer a patient for ketamine or esketamine. They really believe that the patient has to be, I'll even throw a different term out there, ultra treatment resistant depression. But really, a lot of these studies were done when a patient didn't respond to 2 or more antidepressants at adequate dose and duration.
Just 2,
And
right.
just 2. And
Yeah.
we don't think of these treatments. So I find it's really patient specific. And I know that's not, it's not a cop-out answer to say which one I choose, but I'll give an example. If a patient has fluctuating blood pressures, they have hypertension, moderately well controlled, I would recommend IV. The difference is, and I was joking with one of my patients this morning about this, once that esketamine is in you, I can't squeeze it out. I can hit pause on an infusion button, on that infusion pump. From that perspective, I have patients that are terrified of needles, Andy, and they're going, Dr. Harding, you're going to need to give me general anesthesia even before you put this needle in my arm. And so those are the patients that are like, you know what, a nasal spray, I can do it really well. One thing a lot of clinicians don't think about is cold and flu season and the allergy seasons. A lot of times you can't use a lot of nasal decongestants because they're vasoconstrictive and they actually impede the absorption from that route of administration. So it's a lot of moving parts, but I think my biggest advice is really to assess the patient in front of you, because we actually don't have any information just yet about if one of these treatments is better than the other.
Boy, Lisa, that's a good one. I never thought about the decongestant story in cold and flu, allergic rhinitis and so on. That's going to affect the absorption, obviously. And I guess, that comes down to, as always, shared decision-making, just talking with the patient and describing the pros and cons, the differences, getting to know your patient and understanding what their needs and preferences are. That's really helpful. We talked about access and cost. What's the difference in monitoring? I mean, I'm certainly familiar with intranasal and the REMS program. What about monitoring IV ketamine?
So IV ketamine, there are two big papers have been written. One in 2017 by Dr. Sanacora and his group, and the other was written subsequently in the Green Journal by Roger McIntyre. I think both of those have really good data points on what you have to monitor. Intravenous ketamine, of course, you have to make sure the cost and operation of it and why it costs so much, even though the drug is so cheap, is that, think about this, Andy, you have to have somebody that is skilled to put in an IV line. So you have to make sure that IV line is not subcutaneous and not infiltrated, and that ketamine is actually going intravenously over that whole 40 minutes. You're checking blood pressures every 10 minutes because that drug is 100% bioavailable. So the delta of the change in the systolic versus diastolic is definitely different. The risk of allergic reactions, you have to make sure bigger things that you don't think about with the administration of esketamine. The person doesn't have to have a latex reaction, iodine sometimes cleaning patients with allergies to shellfish. And I think one of the key differences is, can a clinician or does a clinician feel that they can sufficiently deliver IV ketamine? Like a lot of psychiatrists or nurse practitioners, after they finish training, PAs, they've taken off their white coat once they entered psychiatry. For them to put on gloves and sort of think about sterility, think about mixing, think about volumes. Remember, esketamine comes in fixed doses. If you're administering intravenous ketamine, you then have to have needles, sharps, disposals, all of these logistical things in thinking about I think the word used was practical difference between the two. So access cost aside, the monitoring aside, how comfortable is a clinician to administer this? I train lots of residents. I do a lot of work with the PGY 3s and 4s, and a lot of nurse practitioners in their training shadow us. And for them, the additional monitoring it doesn't have anything to do with the access and cost to the patient. It has access and cost to the practice and them thinking about how to do that. it costs about, in 2026, it probably cost about $750,000 to build out a practice at the highest level if you want to give patients really safe monitoring care with intravenous ketamine. You have to have the monitors, you have to have the IV pumps, you have to have a supply of saline and needles and all of those things. And I think we don't talk about that aspect of delivering care. We talk about the cost to the patient a lot, but we don't talk about the cost to us as providers to deliver that care.
Well said. So you need, of course, blood pressure monitoring equipment as well. Do you actually put somebody on, and pulse ox, of course, but do you put somebody on a monitor, a cardiac monitor, or you just check blood pressure?
No, and that comes back to why I mentioned those two papers. Both of those papers, I think, collectively talked about the idea that treating the patient is the easy part. The hard part is choosing the appropriate patient. Remember, both ketamine and esketamine have contraindications. And if you read the package inserts, anybody with aneurysmal vascular disease, intrathoracic, intra-abdominal aorta aneurysms, people with hypersensitivity to ketamine or esketamine, those are patients that are precluded from care. And so if a person has had prior cardiac issues, instead of putting them on a monitor, I'm a former ER physician. So for me, that is easy. I do EKGs in my office. We can do one in under 30 seconds on a patient, but that is not the average practitioner. And they may not want to take the liability of having to do that. It is not necessary if for a higher, medium risk patient, you have their cardiologist clear them to say, hey, this is what you need. No, this person should be treated in an academic setting. And you take care of that right off the bat instead of sort of taking on the liability of trying to figure that out in an outpatient setting.
So you would just monitor the blood pressure, I believe you said every 10 minutes or so?
Every 10 minutes with the intravenous. And the pulse ox is on the whole time.
The whole time. And then for how long? Is it like with esketamine that it has to be 2 hours, or how long?
We do 90 minutes. And it varies across the country. We've been trying to poll clinicians to put out some kind of study to see, anecdotally, patients have said right here in Connecticut, some providers have let them go over 60 minutes. And for me, think about this. 3 doses of esketamine going to a patient in 10 minutes, 0, 5, and 10 is 84 milligrams. An intravenous infusion goes in over 40 minutes. So your Cmax is at 40 minutes. I don't see myself letting someone go home 20 minutes after that. I am doing a CADS and a mini MOAS, a MOAS, probably the 7-point CADS on them, and sort of like a discharge readiness checklist to make sure they're okay to go home.
Yeah. Just for people who are not researchers, the CADS is the clinical dissociation scale. The MOAS is the modified observer's assessment of sedation, which, of course, are the two big warnings there. So that makes sense to me that, if you give IV, I would think, the least I would want to monitor is 90 minutes, and maybe...
That's what we do.
Yeah, that makes sense. So there's not a big difference there, let's say,
No.
It's not like a longer monitoring time for the IV or something.
No. And I will tell you that most of the patients seeking care, and, I used to be the vice president of ASKP3, which is the society that all the ketamine providers, not just mental health providers, but those that do chronic pain, just people that provide any kind of care with ketamine. And most patients want to be monitored by doctors. And I will tell you that I've had patients that I've been treating for 5 years, and 3 years in, they didn't have a negative dissociative reaction. And they had one here in office. And overwhelmingly, everyone has said, I'm so glad I'm in a doctor's office doing this.
Well, that's an excellent point. Both the dissociation and the blood pressure elevations are very idiosyncratic. They don't happen every time. And you're raising another issue here, which is in the office. There are, unbelievably to me, Lisa, there are these websites where you can apparently get ketamine shipped, like at home. I've seen troches, sublinguals, these kinds of things.
Yes.
That seems irresponsible to me. I don't know.
It does to me too. And I think there is, I think we don't have, I think as clinicians and I think as a society, we don't have very hard conversations. The hardest conversation is that when there's a loophole in the law, how far can people go to exploit it? And so these are not clinicians that are exploiting it. These are businesses that have found a loophole because the Ryan Haight Act during COVID, we were allowed to do telemedicine. And so we allow for visits to happen via telemed for controlled substances. Ketamine is not regulated. It is off-label. So regulatory bodies cannot tell a clinician how to practice medicine. So if you have a license you can write a prescription for a thing, it's up to the state medical boards to regulate it. And that's all that has happened. And I think I remind most people and regulators that 90% of patients seeking care, even with these at-home versions of ketamine, nobody woke up on a Tuesday, decided, I want to figure out how to become an addict and ruin my life and take treatments that aren't evidence-based. Everyone is seeking care. And I think as the adults in the room and the people responsible for delivering care, we have to do more on the advocacy side in terms of this. And they are the National Pharmacist Board. I worked with them in October of last year. We did a national presentation, looked at all 50 states, look at the prescribing patterns, look at the licenses required, and basically just showing regulators, here's what ketamine is not nefarious, but it is not a panacea. Here's what the appropriate patient looks like. Here are the appropriate indications. And here's the setting in which they should be given. I think we just need to figure out how to help regulators.
Yeah, I agree. And of course, ketamine is scheduled. It's Schedule 3, not Schedule 2. But as you said, and there is the risk of abuse and misuse. The other concern I have is that certainly some of the earlier ketamine clinics, and there's still plenty of them, were started by anesthesiologists and didn't have a lot of psychiatric input. And that concerns me too.
Mine is more of an annoyance. Mine is not so much of a concern. Where are the anesthesiologists trying to prescribe the 2/3 of oral medications that work? We have oral medications that work for anxiety. We have second generation. We don't have a dearth of providers. And with the TRD cohort, you would expect if a person is difficult to treat depression or treatment resistant or ultra treatment resistant, they need some kind of mental health professional driving their care. They also don't understand the doses. Anesthesia, we spent 4 years in residency as psychiatrists figuring out all of the brain circuits that come together to give us this wonderful thing called our brain and all of the emotional regulation and everything. They study how to put people to sleep and they apply that in treating mental health. We don't treat at those doses, and more ketamine does not mean better treatment. That's what all of the studies, even the studies in depression with Carlos Zarate, did not treat at the doses that these anesthesiology clinics are treating at. So I take offense to, I think people think that treating mental health is easy and there's money in it. And we don't have that hard conversation that they can charge a patient $1,200 for one of these infusions and give them a high five with no oversight. So lots of hard conversations to come.
You're absolutely right. That is true. There's another topic I'd like to discuss with you, and that is, you sort of mentioned this, other indications for which there is evidence that ketamine can work. And a couple I'm thinking of, you mentioned bipolar depression. There have been a couple of really good review articles on that. There's been a number of studies, and it does appear that it can be effective and does not appear to have the same liability of inducing mania or destabilizing the patient.
It doesn't. There's also a pretty big study that was published on esketamine. It wasn't done in the US, and they did a retrospective data as well, and it did not. That theoretical switching that happens does not seem to happen with bipolar patients. And the caveat that I will put in here, it would be mania without psychosis. We do not know in psychotic patients, and just like in psychotic depression, we stabilize those symptoms before we use ketamine or esketamine. People will remember that there's in the package insert, patients could have had a history of psychotic depression in TRD, but they weren't precluded from treatment with esketamine. We do the same thing. I carry over that same sort of anecdotal thinking to when I think about bipolar depression. Like it isn't a mixed state where psychosis is a question. The other one is OCD. The other one is OCD as well. There's some small studies that say that showed that it is helpful for the treatment refractory OCD. And I do have a couple of patients, and it is tricky treating them because I pair it together with clomipramine as well. And so it's not, and of course, exposure therapy.
Sure. And the other one, of course, is PTSD. I know the data is a little bit mixed, but anecdotally, I have heard good results there as well.
Absolutely. I think so. And I think people forget that PTSD, anxiety, and OCD really occur by themselves. And I think especially even if you think of people that are touched by certain personality disorders that scare us very much, we forget that when we treat the depression, even the symptoms of borderline get better. The symptoms of PTSD get better. And so we don't treat these patients with these, with these singular diagnoses.
Well said. Yeah, I mean, most patients with PTSD suffer with depression and anxiety, as you said, and it's not off-label. If somebody meets the criteria for TRD and they have PTSD, that's not an exclusion. The label does not exclude you for having PTSD.
Absolutely.
So that's a very interesting thought. And you're right, treating the depression could not help but help. Of course, gosh, that was
Yes.
awkwardly said, but it would likely help, put it that way. Okay, we're coming close to the end of our time, and I really want to make sure that I know. Well, we'll have to talk more again. People will have to come see us at a meeting and do this
Yes.
on stage
Yes.
at some point because we have fun.
Definitely.
I want to make sure that you've said the things that you want to say. Are there any takeaway messages or any, I don't know, pitfalls people need to be aware of or best practices? Anything else you've gleaned from your experience that, especially frontline clinicians who may be thinking about referring a patient, let's say, or monitoring a patient who's getting this?
Definitely, I think we don't have a one of the I think one of the questions you was asking about operationalizing this, the cost, the monitoring. We have embraced AI here in our office. We use a platform called ClinHQ, and that has allowed myself as one physician and a medical assistant to be able to train and deploy these treatments. So in office, we understand the requirements. I think the clinical pearl is even before you think about doing this yourself for a patient, if you want to implement these treatments in office or referring them, really understand what you're getting into. The biggest problem we have across all specialties, just not psychiatry, we're not the only ones feeling, is informed consent. How many times does each of us have a patient in front of us? What med you're on? They can't even say the name, much less tell you even the 9th grade version of the mechanism of action. And I think once we do a better job of educating our patients, and then I always bring it back to we ourselves, what is the cost to us as clinicians? What do we have to know before we roll these treatments out, is understand the liability that we're taking on by doing these referrals or doing these treatments in office. Get the support, embrace AI. Like we use it in our office. It makes us, that monitoring is all taken care of because the monitors are all AI based and related, and it tells us when we have to do what we have to do. So I think our field is moving in the right way. But in terms of basic pharmacology, I think really refer patients earlier. You and I both talked about it. Tried and not responded to 2 antidepressants at adequate dose and duration. That is the appropriate time. The monoamines are not going to work for these patients.
I agree. I always say when you bang your head against the wall and it hurts, don't bang harder. Stop banging. You've banged the monoamines, and now you need to try something different. Another area.
I will feel that.
You may. Absolutely, you may. All I ask is when you speak of me, speak kindly. That's all I ask.
Will do.
One final thing that we didn't really get into in detail, but I think, is somewhat often, and that is concomitant medications. And you said it very well. Sometimes people can't articulate what other medicines they're on. And so one of my tricks, I call it the shopping bag trick. I have a patient fill up a shopping bag with every pill bottle in their house, including over the counter. And you will see some amazing things that people are taking from another prescriber or over the counter or whatever. So I think that's really important too, because, well, first of all, it's funny that with esketamine, it's one of the only psychiatric drugs that's not contraindicated with an MAOI or with stimulants, for instance, although probably you'd be careful about using stimulant on the day.
On the same day of dosing,
Yeah,
it's the same thing.
yeah.
Yes. And Rachel Katz and I think Dr. Sanacora have a paper out on MAOIs used with ketamine, but not esketamine.
Yes.
You just have to watch for the blood pressures and like
Sure.
everything else, you treat the patient in front of you.
Sure.
Yeah, I mean, definitely the key takeaway is do that shopping bag. You got to get the most accurate med rec you can get.
Especially in blood pressure medicines too. You know, I was an investigator on one of the esketamine trials. I'll never forget, I had a patient who didn't take their blood pressure medicine one morning of treatment because they said, I thought I wouldn't take any other medicines. And so I always say, now you've got to tell them, no, take your blood pressure medicine.
Yes. I hope they didn't meet stopping criteria, but yes, definitely.
Because of course you're going to check the blood pressure, and if it's too high, you would postpone the treatment. Makes perfect sense.
Definitely.
One final thing, Lisa, you've mentioned our friend Dr. Jerry Sanacora, and of course you trained with him at Yale. You're being very modest. Also, you know who else trained at Yale? And Yale's famous, of course, for glutamate and the work on ketamine. Our universe, I like to say our universe changed in February of 2001. And how can I be so specific? Someone who trained at Yale and a good friend of mine, Rob Berman, published the first paper of ketamine for depression. And so Yale has a long history there, and you've had wonderful training.
Rob and I are good friends. We are the co-chairs of our alumni association.
Oh, there you go. Yeah, terrific guy. And then, of course,
I am humbled by my company.
Yes. Well, then he went to BMS and led the aripiprazole depression trial. So he has two big things under his belt. And of course, Jerry Sanacora, absolutely wonderful gentleman, and has published some very important articles. Well, Lisa, I can't believe our time is up. I hope this has been helpful to the audience. I've certainly learned a lot, as I do every time we talk. Any final things?
No, I'm waiting to do this live with you in person. I think our learners would have a really good time.
Sounds great. And I would love to be able to take questions, and interact with folks.
Yes.
Too. So thank you, everybody, for listening. For more of our podcasts and more information about NEI products and meetings, please go to our website, neiglobal.com. Our podcast can be found anywhere you get podcasts, such as Spotify and wherever. Thanks so much. Good luck with your clinical work.
Thank you so much.
Thanks for joining us for this episode of the NEI podcast, PsychopharmaPearls. Designed for busy clinicians, these episodes bring you focused insights you can put into practice right away to better care for your patients. Please let us know what you'd like to hear more about by leaving a review. And don't miss an episode. Subscribe today. For more trusted education, visit neiglobal.com.